Okay, so for our second learning objective, we are going to start talking about some of those structural classifications in more detail. So remember, the three major structural classifications of the joints are fibrous, cartilaginous, and synovial joints. So we're going to talk about each of these things a little bit more in depth as we move forward. So beginning with fibrous joints, so fibrous joints have three subtypes of them. And the first type here is the suture. So we all know at this point what a suture is. It's that narrow fibrous joint that's located between most bones in the skull. And as a reminder, the fibrous joints have the fibrous connective tissue. The second subtype here are syndesmoses, and syndesmoses, in these types of joints, the fibrous connective tissue is usually located between two bones. So the bones are really widely separated, just like in the ulna and the radius. And between those bones, they're actually being held together by either a ligament or an interosseous membrane. And so this example is showing you an interosseous membrane. The third and final subtype here of fibrous joints are called gomphoses. And these joints are only located in our sockets for our teeth. So these are really narrow fibrous joints that are between the roof of a tooth and the bony socket in the jaw, which that tooth will fit into. And so there's like a little connective tissue sheath called a gomphosis in between the actual tooth and the bone in which the tooth is going to fit into, and that's holding your teeth in place. So this slide is just showing you the exact same things that I just explained. So again, sutures, they are joints that are held together with really short interconnecting fibers, and they're only found on the skull. Remember, syndesmoses are when joints are held together either by a ligament or an interosseous membrane. And so this example is actually showing you the fibula and the tibia, which are the shin bone and the outer ankle bone, are being held together in this case by a ligament. And the length of the tissue that's holding these two things together, it can vary, but the tissue fibers themselves are much longer than when we compare them with sutures. The, again, third and final type is that peg in a socket fibrous joint. So we have the ligaments, the periodontal ligaments that hold our teeth into the socket that's within our mandible and our maxilla. Okay. So I just talked to you guys about sutures, but as a reminder, sutures form and solidify, I guess, sort of later in life, because whenever we are born, we have what are called fontanelles. And so the newborn version of a suture is called a fontanelle. What's great about these, and what I told you in lab, is that fontanelles have a couple of purposes. So like during birth, fontanelles provide the flexibility to allow basically the skull to get smaller so that the infant can actually move through the birth canal. And then after birth, the fontanelles allow for the skull to actually grow really rapidly, and that this is the major point at which the brain is actually growing. And so over time, usually within 1 year, these fontanelles are going to significantly decrease in their width, and by 2 years old approximately is when they begin to actually sort of fuse together and become the sutures of the adult skull that we learned about. Now, sometimes what can happen if there is a deformity happening or going on, some sutures, the connective tissue actually ossifies, and that causes bones that are sitting next to each other to fuse together. And this is called a synostosis, and there are a few different types of synostoses that you can kind of see listed here. So a lambdoid synostosis, you can see, we know our other side of the lambdoid suture is supposed to be over here on the posterior right side, but it's not there because these two bones have fused together. The unilateral coronal synostosis, so this is when the coronal suture on one side has actually sort of disappeared because the frontal bone and the parietal bone, in this case on the left side, those two bones have fused together. If this happens bilaterally, the coronal synostosis happens bilaterally, then you don't end up with a suture line in between your frontal and your parietal bones. That coronal suture is completely absent. The metatopic suture, so remember how I told you guys during lab that you can see in babies it looks like they have two frontal bones because there is that big fontanelle sort of going right down the middle of the forehead. If the connective tissue here ossifies before it's supposed to, then we call that the metatopic synostosis. And so now the frontal bones have fused before they were supposed to. So you would have like more of a narrow forehead and a bigger, as your parietal bones continue to grow, and your occipital bones and temporal bones, those are still expanding, but your frontal bone is sort of, I guess, mismatched in terms of size, which can definitely lead to problems. And then finally, the sagittal synostosis is when the sagittal suture fuses ahead of time before it's supposed to, and so now our two parietal bones have fused together as one bone. And as you can imagine, each of these types of deformities would causes some problems down the road because your brain only has so much room to grow, and this can lead to increased pressure on the brain, and ultimately could potentially lead to death if it's severe enough. So now that we've covered the three major types of fibrous joints, we're going to move into the two subtypes of cartilaginous joints. And so the first subtype that I'm going to talk to you guys about is called a synchondrosis. And these cartilaginous joints are made of hyaline cartilage. So for an example, our epiphyseal plates their classification would be a synchondrosis because it is a joint that's made of hyaline cartilage. The other situation that can occur here, another type of synchondrosis, would be where a bone would be united to a cartilage structure. So we learned about ribs, and we know on the anterior side of the ribs over here, and over here just lateral to the sternum, we have that excuse me, the costal cartilage. The costal cartilage is an example of a synchondrosis as well. So it's connecting the rib bones to the sternum. Okay. And then the second subtype here is the symphyses or symphysis. Symphysis would be the singular and symphyses is the plural. And symphyses are composed of fibrocartilage. So synchondrosis is hyaline cartilage, and then symphysis is fibrocartilage. And so a couple of examples of symphyses would be things like the pubic symphysis, which is what you can see down here. It's in between, it's that blue structure, that's in between the two hip bones. Another example would be our intervertebral discs. I had that picture up a couple of slides ago where you have the two vertebrae that are right next to each other, and then in between them is a little disc. It's like a little shock absorber, so every time we walk and stuff, our bones don't hit each other. That would be an example of a symphysis. So this picture is just, again, from the Marib textbook. The last picture was from the OpenStax book, but this one's from the Marib textbook, and it's just, again, re-explaining the types of cartilaginous joints. So the synchondroses, they are occurring where bones are united by hyaline cartilage, like the epiphyseal plate or the cartilage that connects the ribs to the sternum. And then again, the symphyses are present in locations where the bones are united by fibrocartilage, like the intervertebral discs and the pubic symphysis. So that takes care of our fibrous and our cartilaginous joints. And now we begin our discussion on synovial joints. And I think for the most part, the rest of the lecture is covering different aspects of synovial joints. So just some key features about synovial joints. They contain a joint cavity, and a joint cavity is a fluid-filled space where the articulating bones are actually contacting each other. But again, remember, this is fluid-filled, okay? So the fluid can act kind of like a cushion. And so I'm kind of outlining with the pointer here this joint cavity. In addition, another key sort of element of synovial joints is that the articulating surfaces don't actually directly connect to each other with fibrous connective tissue or with cartilage. And because these bones aren't physically connected to each other, this gives us more mobility in places where synovial joints are present. So we have several different subtypes here of synovial joints, and these categories are based on the shape of their articular surfaces and then also their ability to move. So for example, non-axial synovial joints only do a gliding movement, and non-axial so only a gliding movement. This would be, for example, these plain synovial joints. So here would be a plain synovial joint example. Uniaxial synovial joints do movement in one plane. So the two subtypes of uniaxial synovial joints are the hinge joints, like at our elbow. So we know our elbow really only, get myself in camera here, our elbow really only does one kind of planed movement. So it only flexes and extends. And so this is what it's referring to by movement in one plane. It's like across one axis. If you are, let me just draw this. I think I can draw one here. So when we're talking about planes, we know we have an x-axis and a y-axis here. And then we know we have this one that's kind of going this way. Sorry, my drawing's like not going to be great, but I'm trying. Okay, we have this like z-axis. And so in one axis, if you think of the x-axis as being your elbow, we know our elbow only goes kind of up and back down, up and back down. And so this is what I'm referring to by uniaxial movement. In addition to these hinge joints, we also have pivot joints. And so an example of a pivot joint is the one that occurs between the atlas and the axis. And so this one that allows us to shake our head no. This is movement that's occurring in just one plane. I also, if you kind of don't really understand pivot, I like to give the example of if any of you guys have ever played basketball or know anything about basketball, when you're at holding the ball and you're standing there, you know, you can't move 2 feet, but you can still move 1 foot around, and they call that pivoting in basketball also. So that's kind of the same sort of situation that's going on with the pivot joints here. The next types of movements are biaxial, and so biaxial synovial joints have movement in 2 different planes. And so this includes the condylar and the saddle joints. And so get back to my pointer here. So our condylar or our condyloidal joint, for example, between the radius and the carpal bones of the wrist. So we know for the most part we can, with our wrist, kind of do this motion, and we can kind of go side to side. So this is really like 2 planes. So we're going front and back and also side to side. The saddle joints, this would be, for example, between the trapezium and the first metacarpal. So this is our thumb joint here. This one is a saddle joint, so it can also move in 2 planes based on its shape, and that's kind of what this is showing you, that it can kind of rock sort of side to side and front and back as well. And then finally, multi-axial movement is referring to movement that's in or around all 3 planes of space and axes. So the example for this one is our ball and socket joint. And the ball and socket joints are present in the hip and then also in the shoulder, but these allow us to have like a full 360-degree movement around all 3 planes. So we're going to go into detail a little bit more about each of these categories of synovial joints. So as a reminder then, the first type of synovial joint that we're going to talk about are plane synovial joints. And as I mentioned on the last slide, these ones do non-axial movement. And so that is just gliding. So basically the way that the book likes to explain it is like that if you have a box and you put it on the floor and you just kind of like slide the box around, you're technically gliding the box against the floor. And so some areas where this occurs are things that are, or areas would be like in between our carpal bones. So in between each of the bones that are actually in our hands, our wrist bones. Additionally, between the tarsal bones in our feet, and finally between vertebral articular surfaces. So in between the vertebra, all of those joints would be classified as being a plane synovial joint that can only do gliding motion. The next type here, this is when we start talking about the uniaxial synovial joints. And so the first one here is a hinge synovial joint. So if you can kind of imagine a cylinder going through a trough, it's kind of representing our humerus and our ulna coming together. And we know that what these look like because we've seen them in lab. We have that big olecranon process coming off of the ulna, fitting nicely onto the capitulum and the trochlea, and then articulating into the posterior side of the humerus on the olecranon fossa. And so basically when these 2 things meet up, we get this flexion and extension movement. Okay, so uniaxial, it's just going along one axis. Okay, and so in addition to the elbow joint, another example of this would be our interphalangeal joints. So we can bend our fingers and extend our fingers, so we can flex and extend our fingers because the joints where each of our phalanges are meeting up, so our proximal, medial, and distal phalanx, where each of those meet up, we'll have this joint that is considered a hinge joint, so it allows flexion and extension. The second type of uniaxial Synovial joint, again, is these pivot synovial joints. And so the example here that's given is the proximal radial ulnar joint. Okay, when the radius and the ulna come together closer to the elbow, that's what it's talking about when it says proximal radial ulnar joint. So up here where the radius and the ulna are coming together, so on the proximal side, closer to the elbow. Basically, I told you that in lab that the radius, the head is very circular and it kind of fits into that notch on the ulna, and it allows us to go from palm up to palm down because it's essentially the ulna is staying in place and the radius is rotating over top of the ulna as we move from supination. I'm going to try to do this here, just not sure how. Okay, so we move from supination to pronation. So from supination, so from palm up to pronation, your ulna actually isn't moving. It's your radius that is rotating over top of your ulna. And so this is a uniaxial movement that's occurring in one plane, and specifically pivot joints do rotation. So in addition to this proximal radial ulnar joint, the other one that I mentioned before was the atlantoaxial joint. So the one that allows us to shake our head no is also a pivot joint. So now we can move on into joints that allow biaxial movement. And so the first subtype here are these condylar synovial joints. And these condylar synovial joints have oval-shaped articular surfaces. And so an example here would be these metacarpophalangeal joints. So for example, this is between the actual finger, so between the finger and then the bone that's actually in this hand region. So these joints right here at the base of our fingers are condylar synovial joints. So they allow both flexion, so they allow us to flex our fingers and extend our fingers, but they also allow us to expand our fingers and bring them back together. So abduction and adduction. So in addition to these knuckle joints being condylar, another example is our wrist joints also tend to be condylar. So this part here of our hands allows us to do flexion and extension and abduction and adduction. Okay, so up, down, side to side, right? So biaxial movements in two planes. Both allows us to go anterior and posterior, and medial and lateral. The next type of biaxial synovial joints are the saddle joints. And so this type of joint, it kind of looks like the articular surfaces of are basically, one is concave and one is convex. And so because of this, an example here is going to be our thumb joint. Excuse me, between the first metacarpal and the trapezium here, sort of this would be like kind of down. So here's the first metacarpal, and the trapezium is kind of the notch that's just sort of just distal to the wrist. So this joint here is a saddle joint, and it allows the thumb to perform both flexion and extension, but also adduction and abduction. Okay, so these are the four movements that saddle joints can do, and then also it's the same movements that condylar joints could do. Finally, that leaves us to the multi-axial synovial joints, and remember, these are the ball and socket joints, and I told you that these are present in the hip and also in the shoulder. So these are the ones that can do movements in all planes, and it's literally like a ball fitting into sort of a cup. And this allows us to do flexion, extension, adduction, abduction, and also rotation, rotational movements. And so, excuse me, this one gives us the most mobility, are these ball and socket joints, which is why we're able to move our arms in all planes and our hips in all planes for the most part as well. All right, so now that we've talked about some different types of synovial joints, I'm going to start talking to you about the structure of synovial joints. So these are just in general some different structures that synovial joints have that are kind of unique to them. So first and foremost is the articular cartilage. And the articular cartilage is outlined here in this blue, and it's essentially hyaline cartilage that's going to cover the surface of where two bones are meeting up. So the surface of each bone is going to be covered by this articular cartilage. And the function of this articular cartilage is just to absorb any kind of compressional forces that are placed on the joint so that the bones are not crushed. The next structural feature of synovial joints is what's called the joint cavity. And so you kind of see it everywhere within this green and blue little space. This would be considered the cavity. And the cavity is a feature that is unique to synovial joints and contains a really small amount of synovial fluid. The cavity is called a potential space because it's normally essentially almost non-existent, but it can expand if fluid accumulates in this area, like would happen during like inflammation from an injury. So just the space within here is called the cavity. And then the next structure we refer to as the articular capsule or the joint capsule. And essentially what this is it's the connective tissue structure that's going to enclose this cavity. So it has a couple different layers. So first and foremost is this fibrous layer or the external layer. So you see the fibrous layer would be this white layer, and essentially all the fibrous layer is dense irregular connective tissue that is continuous and derived from the periosteum of the two bones that are articulating. So remember, the periosteum is the saran wrap that's kind of wrapped around the outside of all bones. And so the periosteum at this joint space is going to give rise to the fibrous layer of the articular joint capsule. The function of this external layer then would be to strengthen the bones so that they aren't actually pulled apart. And then the second component of the joint capsule is the synovial membrane. The synovial membrane is the thin layer of loose connective tissue. So it's outlined here in green on both outer surfaces here. Both medial and lateral side, it's outlined in green, but essentially what it is, it's this thin layer of loose connective tissue that lines the inner surface of this joint cavity, and it also covers any surface that is not covered by the hyaline cartilage of the articular cartilage. And the function then of the synovial membrane is to make synovial fluid. So I just mentioned that the synovial membrane function is to make synovial fluid, but what is synovial fluid? Essentially all that it is this slippery fluid that is going to occupy any free space that's inside of this joint capsule. So remember, I said the joint cavity is this potential space, and this is inside of this cavity is where the synovial fluid would be located. Synovial fluid is derived from filtration from the blood flow that is running through the capillaries in the synovial membrane. So the synovial membrane actually does have capillaries that are supplying blood to it, but essentially what happens is that the membrane here is going to filter out some nutrients and put it from the capillaries then into this potential space within this joint cavity in the form of this synovial fluid. So its synovial fluid consists of, or its composition is kind of this viscous egg white sort of consistency, and this is due to the hyaluronic acid that is secreted by these synovial membrane cells. However, during joint activity, the synovial fluid becomes a little bit thinner, and also the synovial fluid contains phagocytes to rid the cavity of any microbes or cellular debris that might be present there. So the whole purpose of having this fluid is to reduce the friction between the articular cartilage. So we remember the articular cartilage is going to be present here in blue and then here. And by placing a fluid in between those two, now we have less friction. It's kind of like if you wet something down, if you're rubbing two wet things together, they just go together, they slide more easily. It's kind of like putting grease or oil on something. That's just going to make it move more easily and decrease the amount of friction that's present. So without having this fluid, then we can imagine that the rubbing together of these articular cartilages, if no fluid was present anywhere, that would wear away the surfaces of the joint, and not to mention, just like rubbing your hands together really fast creates heat, any kind of excessive friction here could overheat, and that would destroy the tissues of the joint itself. And so kind of the way that synovial fluid works is in this process called a weeping lubrication. So this occurs when fluid is going to be forced out of these articular cartilages into this space whenever the joint is under pressure. And then when the pressure is dissipates or is gone, the fluid is going to kind of move back into these cartilages again. So it's kind of like when you squeeze out a sponge. So you're putting pressure to that sponge and you're squeezing out the water, and then you put the sponge back down into that water-filled bucket, and it's going to reabsorb the water. So again, the purpose here then would be to lubricate all these free surfaces of the cartilage, specifically of this hyaline cartilage, and nourish the cells of these cartilages, because even though the synovial membrane gets direct blood supply from capillaries, cartilage itself is avascular, so there's no blood supply directly feeding the cartilage, so it doesn't get its nutrients directly from the blood, and so instead it gets nutrients from the synovial fluid and through this weeping lubrication method. So the squeezing out of the fluid and then reabsorbing the fluid is going to nourish the cells here. So in addition to talking about synovial fluid, some other structures that are important to realize are present would be things like the reinforcing ligaments, which are composed of fibrous connective tissue, and their function would be just to anchor the bones together that are present at these synovial joints. And there's a couple of different types of reinforcing ligaments that I'll kind of go through with you. First type here would be capsular ligaments, and Capsular ligaments are just a local thickening of that fibrous layer of the capsule. So remember on the last slide I was talking about the fibrous layer is just the extension of the periosteum. These capsular ligaments then would be that extension of the fibrous layer. And I just noticed that there's a spelling error on here too. That should say layer. The capsular ligaments are going to be found in joints that are going to bear a lot of weight, and they function to just enhance their strength. So for example, in the hip joint, so that's this first picture that I have up here. So here we can see kind of through and into the right hip joint. So here's the femur and here's the hip bone over here. We can see the synovial cavity is in yellow, and then we have this capsule here, the articular capsule. And this capsule then is going to be reinforced by ligaments. So the thickening of this capsule is going to form the iliofemoral ligament, and as you can see there's two sections of it that are traveling from the femur to the coxal bone, and that is reinforcing the femur and holding the femur in place up against the hip bone. So it's really just for structural reinforcement purposes, particularly for joints that bear a great amount of weight like the hips. The next type that I'm going to talk to you guys about is intracapsular ligaments, and intracapsular ligaments are actually found inside of joint capsules, and their function would be to reinforce the connections of the articulating surfaces. So an example of these types of ligaments would be like our ACL and the PCL in the knee joint. So we would have articular cartilage here on the condyles of the femur, which you can see in this like light blue color. And then here's the tibia, and it's going to have its cartilage as well. And so in order to sort of reinforce these connections, we have ligaments that are going to hold the joint together, and in this example the ACL and the PCL, and because they're located actually inside of this joint capsule, they're called intracapsular ligaments. And then finally the third type are extracapsular ligaments, and what extracapsular ligaments do is they actually wrap the joint from outside of the capsule and hold that capsule in place. And this prevents dislocation. So an example here would be the fibular collateral ligament of the knee, and also the medial collateral ligament. So your LCL, by the way, the fibular collateral ligament is the same thing as the lateral collateral ligament. And the medial collateral ligament is also sometimes called the tibial collateral ligament. So your MCL and your LCL would be examples of extracapsular ligaments that are present outside of the joint capsule and function to help hold that joint capsule in place and prevent dislocation of those structures. So in addition to ligaments, we also have some other structures within synovial joints. So for example, articular discs and menisci. Essentially these are just fibrocartilage that are separating the articular surfaces, and the whole point of having these is just to really improve the fit of the bone ends, to help stabilize the joint and reduce the wear and tear. So an example here that I think most people are familiar with are the menisci that are located in your joints, your knee joint, your medial meniscus and your lateral meniscus, and these are like little shock absorbers. So the articular surfaces would be this part of the femur up top, and then just below these menisci would be the hyaline cartilage for the articular surface of the tibia. So in between the two articular surfaces we're finding these menisci, and they just provide an extra cushion layer sort of whenever we're weight bearing on our knees. In addition to articular discs and menisci, bursa are these bags of synovial fluid that function to reduce the friction where ligaments, muscles, some skin, tendons, or bones might rub together. And so that's this top picture over here. So this would be in the shoulder. So here is, it looks like this is the acromion, and then here's the head of the humerus. And so the bursa is traveling between the head of the humerus and the ligament here. This is probably the AC ligament, acromioclavicular ligament. And so in between those two structures, you'll find this bursa. And this is just so that the ligament won't touch and rub heads with the hyaline cartilage that's lining the head of the humerus. All right, so to prevent that wear and tear, just kind of like the menisci do, similar function. In addition to then bursa, we also have tendon sheath. And tendon sheath is basically this long fluid-filled sac that's going to wrap around a tendon that passes through a joint space to decrease the friction then of that tendon. So within the shoulder, we have, so here is the acromion of the scapula, and the subacromial bursa, which is the one that you saw up here in this top picture. But we also have the tendon for the biceps muscle. So our biceps muscle, I'll try to do this in camera, this makes it hard. Okay, sorry. The biceps muscle essentially is going to come up into the shoulder and attach that way. So it actually has to cross the joint space. And so the tendon, and just so we are reminded, tendons connect muscle to bone. The tendon for the long head of the biceps muscle is going to pass up through the shoulder joint, and as it passes up through the shoulder joint, it's just going to be wrapped in this sheath that's going to decrease the amount of friction that's present so that the tendon isn't subjected to friction, which could potentially cause tearing of it. So on the last slide, I told you guys about bursa and what they are, but there's actually a few different types of bursa. So for example, the first type is called a subcutaneous bursa, and subcutaneous bursa are located between skin and bone. So an example of this would be the prepatellar bursa that's located just outside of the kneecap, in between the skin and the patella, or the kneecap bone. So we're going to have a little bursa there. In addition to the subcutaneous bursa, we also have submuscular bursa. And so these submuscular bursa then are located between a muscle and a bone. So they can also be located between two muscles that are sitting next to each other. So an example of this would be the trochanteric bursa. So here you can see the trochanteric bursa of the right hip. It's essentially going to be in between the muscles of the gluteus maximus, and this would be the TFL, the tensor fasciae lata muscle. It's going to be located in between the muscle and the head of the femur. Finally is the subtendinous bursa. And the subtendinous bursa are located between a tendon and a bone. So examples of this, the one that I have up here for the picture would be the suprapatellar bursa. And so here is the tendon of your quadriceps muscles. So this is the one that's going right down the middle of your leg, this particular muscle. And then it comes to a tendon, and that tendon attaches the muscle of your quad to your kneecap bone, to your patella. So you're going to have this tendon, and just beneath that tendon is where you're going to find this suprapatellar bursa. And again, the bursa is there just to reduce the friction between the bone and the muscle, because you don't want those two things rubbing together. As you can imagine, if you bend your knee, these things would become closer in distance, and you don't want them rubbing together because that can cause damage to both the tendon fibers and to the actual bone tissue.